I'm sure Ravindran sir is yet to join. Jawahar sir is on the traffic. He should be joining 5 minutes, but let us start the class on time. So we have good evening, friends. On behalf of all the faculty here, I share a very happy New Year to wishes to all of you, and a prosperous year filled with lot of learning and successful career for all the young PGs who are aspiring to go for higher studies. Ravindran sir, good evening, sir. Welcome.
Good evening, sir. Happy New Year, sir.
Happy New Year, sir. So, friends, we have two important cases. I hope all of you, many have been awarded awards in the Ethicon Mumbai. Many we could see you in person. Many, all the faculty, I share their blessings also to all of you for a bright career in the subsequent year and to your overall career as well. Friends, we have two cases. One is kindly contributed by Professor Shilpa Rao. Ma'am is from KM Mumbai. We have Dr. Omkar Joshi, who is going to present a case of parotid swelling. The other case is kindly contributed by Madam Kalevani from Bangalore. She is a professor and head of the department at Saptagiri Institute of Medical Sciences and Research. We have Dr. Arshia Sultana, who is going to share a case of thyrotoxicosis. So this will be the last class for the year 2022. And I'm sure we are going to bring in small changes after consulting with the senior faculty here. But we look forward for your continuous presence and these classes will go on. Thank you very much. Now I invite Dr. Omkar. Omkar, please introduce yourself, your unit chief, and then you are head of the department and start your presentation. Good luck to you.
Yes.
Santosh has joined, sir.
Sorry, sir.
Santosh has joined. Santosh Kumar.
Oh, very good, sir.
Hi.
Santosh, sir, good evening, sir. Okay. I think he's having issues. Sir,
evening,
are
sir.
you okay? Good
Okay,
evening,
sir.
sir.
Okay. Good evening, sir.
Thank you very much, sir. Faculty, please take over.
Shall I start, sir?
Yes, sir.
Please share your PowerPoint and start your presentation.
Yes. Good evening to all the faculty members. Myself, Dr. Omkar Joshi. I am a third year PG in General Surgery at St. GS Medical College in KM Hospital, Mumbai. My guide is Dr. Samir Rege, sir, and HOD is Dr. Varsha Kulkarni, madam. Today, I am going to present a case on the parotid swelling. So we had a 38-year-old gentleman, a corporate office worker by occupation from Mumbai, who presented to us with swelling in front and below the left ear lobule since the last 6 years. Patient was apparently all right 6 years back until he himself noticed a small below the left ear lobule, which was insidious in onset, gradually progressed to attain the present size over the period of 6 years. The swelling was not associated with any pain or while chewing food. There was no history of change in size of the swelling while chewing food. There was no history of sudden increase in the size of the swelling. There was no history of fever, purulent discharge in the mouth, or even rise of temperature. There was no history of asymmetry of face, difficulty in closing eyes, difficulty in chewing food, drooling of saliva from the angle of the mouth, no history of difficulty in opening the mouth, no history of difficulty in swallowing. There was no history of dryness of eyes, mouth, or joint pain. There was no history of earache or ear discharge. There was no history of any other swelling on the contralateral side of the face or neck or anywhere else. No history of loss of weight or appetite, breathlessness, or bone pain. Past history, the patient did not have any significant history of comorbidities like diabetes mellitus, chronic liver disease, tuberculosis, connective tissue disorder. There was no history of radiation exposure in the past. There was no history of previous surgery or prolonged hospital stay. There was no history of any drug allergy. Patient consumes a mixed diet. Sleep and appetite is normal. Bowel bladder habits are unaltered, and patient denies any addictions. The family history is insignificant. So, summarizing my history, the patient, we have a 38-year-old male with no known comorbidities, presented with a painless, gradually progressive swelling in the front and below the left ear lobule since the last 6 years, with no symptoms suggestive of any local invasion, probably a case of a benign parotid swelling. Should I move on with examination, sir?
No. Please wait. Go to the first history slide. Let the faculty finish discussing the history part. Then you can go to the.
Yes, sir.
Omkar,
Yes, sir.
the patient's chief complaint is swelling in front and below the left ear lobule.
Yes, sir.
Did he say that or you ask about that?
Sir, he mainly presented with the swelling. He initially stated that it was below the left ear lobule, which he himself noticed while looking at himself in the mirror or something.
And he said it is in front and below the left ear lobule.
Initially, sir, it was only below the left ear lobule. Gradually, over the 6 years, he has said that it has slightly progressed near the front of the ear lobule.
But what exactly the patient said?
Sir, patient had described the complaint as the swelling which he had noticed 6 years back, which was below the left ear lobule, which was lifting it up. And there was no other complaint associated with that swelling, but it gradually increased to the current size over the course of 6 years without any other presenting complaints with the swelling.
This patient must have said to you that there is a swelling on the left side of the face near the ear lobule, isn't it?
Yes.
And you never say it lifted the ear lobule. Patient never says that. This is our inspectory finding.
Yes, sir.
Okay, so the patient will never say that it is lifting the ear lobule or below the ear lobule. No, it will be just it's around the ear lobule which is there.
Yes.
Okay, go to the next slide. Okay, go to all those no slides. Very yes. Why did you ask about history of sudden increase in the size of swelling?
Sudden increase in the size of swelling can be one of the causes of transformation of a benign parotid swelling, which can be there, or in cases like when the patient is having food, there can be sudden increase in size of swelling due to silodenitis. So that's why I asked both that history.
So what is the difference between sudden increase and the rapid increase?
Sir, rapid increase will be there in the previously present swelling, which is there since a very long time, and now it has rapidly increased over the course of like 1 month or so, pointing it towards mostly some malignant transformation of benign swelling.
All right. And usually the sudden swelling is because of?
So sudden swelling can be because of parotid abscess or silodenitis, which can present along with a pain.
Yeah, but usually when you say the sudden usually it is because of hemorrhage. That there is some hemorrhage going on that will lead to a sudden size, no?
Yes, sir.
Okay. Why did you ask about history of fever, purulent discharge in the mouth, evening rise of temperature?
Sir, again, to rule out inflammatory conditions of parotid, like parotid abscess or something. So I had asked history of associated fever and purulent discharge, which can be seen in the mouth at the opening of the Stenson's ductus.
And you said evening rise of temperature.
Yes,
Why
sir.
is that? Why is that?
Sir, generally in case of tuberculosis, associated complaint is evening rise of temperature. So it can also present as the swelling can also be a lymph node in the neck. So which in our country, most common cause of it is tuberculosis.
Okay.
In that case, you should also try to rule out other causes which can lead to lymph nodal enlargement in upper neck, not only tuberculosis, right?
Yes, sir.
It is good that you have looked for tuberculosis, but you should, if you are thinking of lymph node, you should also think of the drainage area in the upper neck region and all pathologies related to that. Good, very good.
Because in the provisional diagnosis, you have only kept in your, you should not keep all those things, what you have put in the, okay.
Yes.
You never get a tuberculous peritonitis.
Yes, sir.
Okay, we have not heard about the tuberculous peritonitis. Okay, so it cannot be just a parotid swelling which you are keeping as a diagnosis there.
Okay.
You have to always keep on the lymph nodes there in that area. Right?
Yes.
Right. Why there is no history of difficulty in opening mouth? Why did you ask that?
Sir, when there is involvement, if there is involvement of any deep lobe and it can go to the pre-articular fascia of the temporomandibular joint of the same side, which will cause difficulty in opening of the mouth. So jaw movement will be restricted in that.
So if there is a swelling which is there in the parotid region, what are the various causes for difficulty in opening the mouth?
Sir, one of the thing which I told is involvement of deep lobe of parotid gland, which will cause difficult. And if there is a malignancy suspected, which is going to the prearticular fascia of the
Common thing first. Sir wants to know about the infective causes.
Commonly, sir, inflammatory conditions or abscesses can also present with pain, which will cause difficulty in opening. So patient will himself restrict the movement of the jaw so as to not cause any pain on the swelling side.
Mumps parotid.
Which muscle should be involved that the opening of the mouth is not adequate?
Sir, mostly, sir, pterygoid muscles are involved if there is a restricted jaw movement.
All right. Okay. So when do you say it is an inadequate opening of the mouth? When do you say it is an inadequate opening of the mouth? When do you label that? Are you there, Omkar?
Yes, sir. Yes.
Okay.
Not
Do you know or you do not know that?
No, sir. I don't.
Okay. So there should be at least 3 centimeter distance between the two incisors here.
Okay.
Okay. Or the patient can put the 3 fingers in between the two incisors. Then that is an adequate opening.
Yes.
Any opening less than that is an inadequate opening here. Okay. Why did you ask about history of difficulty in swallowing?
Sir, if there is some deep lobe involvement in the parotid region, which lies in the parapharyngeal space, so there will be difficulty in swallowing. The patient will have that history of difficulty in swallowing.
Why no history of dryness of the eyes, mouth, joint pains?
Sir, as parotid swellings can also be associated with autoimmune conditions like Sjogren's syndrome,
Yes.
we have to rule out.
Okay. History of earache and discharge?
Sir, associated ear infections like otitis media can also present with localized infections near the parotid region. So that might be one of the inciting factors.
But can a parotid swelling itself can cause the earache?
Sir, yes, sir. Referred pain can be there, parotid swelling.
Auriculotemporal nerve is there.
Yes, sir. Auriculotemporal nerve.
Right. No history on the other side. So tell the causes of the bilateral swelling, bilateral parotid swelling.
Sir, commonly seen in case of chronic alcoholics, bilateral sialadenosis. Then it can also be seen if in old age people like who have Warthin's tumor, as they have bilateral presentation of parotid swelling bilaterally.
So tell the causes of that. Causes of the bilateral parotid swelling.
Yes, sir. One of it is, sir, chronic alcoholism. Next is Warthin's tumor can present bilaterally.
Good.
And
Patient is in the ICU.
yes, sir. Poor oral hygiene due to intubation. So parotitis can also present as a bilateral swelling due to poor oral hygiene and intubated state of the patient.
Okay. You said the Warthin tumor. Any other tumor which can be bilateral?
Warthin's is most commonly.
Any other tumor which can be bilateral?
Where you don't operate actually. Lymphoma.
Lymphoma.
Yes, lymphoma.
Lymphoma can be bilateral.
Mumps parotitis.
Mumps is that. So the commonest cause is the bilateral parotitis because of poor oral hygiene, and the bilateral mumps are there.
Mumps. Yes.
No history of loss of weight, appetite, breathlessness, bone pain. Why that?
Again, sir, loss of weight, appetite can be constitutional symptom for any malignancy. Breathlessness, again, to just rule out, sir, any pulmonary pathology like tuberculosis.
Okay, can go to the next slide.
Why
Yes.
bone pain? Why bone pain?
Why bone pain? Yeah.
Sir, to rule out any secondary involvement.
Carcinoma.
Sorry, sir.
Which carcinoma in parotid will lead on to bone pain? So high-grade mucoepidermal carcinoma.
Yes, sir.
Omkar Joshi, Dr.
Yes,
Raju
sir.
here. Just
Yes, sir.
one or two small comments. You are asked so many questions. All that is fine, but little bit of rearranging will fetch you more marks. What I am trying to tell is, you
Yes.
have a patient who has got a 6 years duration of the swelling, correct?
Yes, sir.
Do you suspect a fever and purulent discharge? 6 years,
No.
right? So
No.
we'll just look at the order in which you have put. So if you
Yes.
can arrange, whenever you have a patient who has got a 6 years duration of a swelling in the region of parotid, immediately you should have mind start thinking, what are the possible things in the back of your mind? No
Yes.
doubt everyone
Yes.
knows that it's a tumor. There's no doubt
Yes.
about that.
Yes.
Keeping that in mind, few things related to the tumor should come first. Yes, you have mentioned every point here. And look at the etiological background of the tumor, in the sense whether it's a tumor or you mentioned some are alcoholic cirrhosis and all that thing. So some of the other causes of enlargement, including some benign swellings, which can occur in the parotid region.
Yes.
Again, when you are, asked the questions of bone pain, I would have given more preference if you go ahead with the autoimmune etiology. Never forget this autoimmune for the salivary glands. That
Yes.
joint pain should go up. Understand?
Yes. Yes.
Especially autoimmune pathology. And
Yes.
again, the earache, the
Yes.
reasons are auriculotemporal and the branches of the, all these, trigeminal nerve, mandibular division, in that tympanic membrane also supplies, including the auricle here. So that's why
Yes.
all these things will happen. Okay.
Yes.
And again, that last sentence, all this weight, appetite, breathlessness, bone pain. So, sir asked you that metastasis to suspect. More importantly, adenoid cystic carcinoma. I mentioned to you, local infiltration, etc. So
Yes.
little bit of rearranging the things, which will achieve more marks. So just look at the etiology of the parotid region swellings, then you'll be able to do well. Okay,
Noted, sir.
that's all, sir.
Santosh, you are asking any question?
Sir, Dr. Omkar,
Yes.
what
sir.
is the difficulty in chewing food you expect in parotid tumors?
Sir, inflammatory pathologies will restrict the jaw movement, sir. The patient will have pain. And if the patient has silidinitis of the parotid gland, so there will be pooling up of secretions in the parotid. So patient will have some pain associated with that while he takes food.
Is there any weakness for chewing, or due to some other thing the chewing is impaired?
Sir, if there is involvement of masseter muscle in the carcinoma of the parotid, that will be affected. The chewing of the food, patient will have a difficulty in that.
What is the difficulty happens during chewing?
Sir, there is inadequate closure of the mouth, and the patient will not be able to chew from that side of the mouth due to inadequate pressure.
Okay. Muscle weakness producing collection of food in that cheek.
Yes, sir.
Okay,
So there
that is a
will be-
difficulty. Okay, can proceed.
You can go to the examination part now.
Yes. Patient was examined in a well-lit room in sitting position after informing verbal consent. Patient is conscious, oriented in time, place, and person. The height 69 kgs. We have 168 centimeters. BMI is 25. ECOG score is 0. Patient did not have any pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. Vitals of the patient were pulse with 82 beats per minute. This is regular. BP is 130 by 72 millimeters of mercury in right arm supine position. Respiratory rate of 20, and the patient is afebrile. Local examination. On inspection, swelling was seen in front and below the left ear lobule, extending superiorly just below the tragus, anteriorly approx 1.5 centimeter from the ear lobule, posteriorly 2 centimeter behind the ear lobule, inferiorly up to the angle of the mandible. Swelling is approximately 3 to 2 centimeter size, ovoid in shape with well-defined borders, and surface appears to be regular. The skin over the swelling shows no color changes, no dilated veins, scars, or sinuses or ulcers. Position of the left ear lobule appears to be displaced slightly upwards. Facial symmetry appears to be normal. The right parotid region appears to be normal, and no other swelling is noted in the neck. On palpation, there was no local rise of temperature or tenderness. The inspectory findings were confirmed. On palpation, there is single swelling in the retromandibular fossa below the left ear lobule, approx 2 by 2 centimeter size, ovoid in shape with lobulated surface, with well-defined margins, and the skin over the swelling was pinchable. The swelling was firm in consistency and mobile in both horizontal and vertical directions. Swelling could not be moved above the zygomatic arch. The swelling is not fixed to the underlying masseter muscle. The parotid duct palpated to be normal along the anterior border of the masseter muscle. The left parotid region is normal with no swellings palpable, and there was no cervical lymphadenopathy which was palpable. On examination of the oral cavity, the oral hygiene is maintained. There was no halitosis or dental caries. Uvula was central and there was no bulging on the left tonsillar fossa. The parotid duct opening was normal with no blood or pus discharge on palpation and was normal. The movements of the jaw were not restricted and were found to be normal. So, based on the diagnosis, it is a benign swelling arising from left parotid gland without any evidence of local surrounding structure invasion, most probably a case of pleomorphic adenoma, to be confirmed with the following investigations.
Go to your slides, sir.
Okay. Okay, Omkar. In this, you have written all peripheral pulses felt equally.
Yes.
What does that mean?
Sir, in all the 4 limbs we check for peripheral pulses if they are equal.
So is it a good term to be used? You understand all the pulses?
No, sir. So
all the pulses are only of the limbs? Do you feel any pulses in the head and neck area?
Yes, sir. A superficial temporal can be felt near the temples. Facial artery can be felt, sir, at the border of the masseter, and carotid arteries can be felt, sir, in the neck.
So that term is not good, is it?
Okay, sir.
That you have felt all the peripheral, and in fact, it is never, this term is never used, that they are felt equally. Okay.
Yes.
This is not a good line to be used in the presentation.
Yes, noted.
How do you make a masseter taut?
We ask the patient to clench the teeth, so makes both the masseters taut.
If you have to make a mylohyoid taut, how will you make the mylohyoid taut? Like there is a swelling which is there in the midline of the neck or slightly on the lateral side in the submandibular area, and you want to check whether it is in relation to the mylohyoid.
I don't know.
Okay. You ask the patient to push the palate with the tip of the tongue. Okay, if you try yourself, you will find that the mylohyoid becomes taut.
Yes.
Okay. Right. Did you feel the parotid duct in this patient?
Yes, sir. Parotid duct was examined. It was found to be normal.
So how did you feel that?
Sir, the proximal part can be felt by palpating the palm of the by the tips of the fingers on the anterior border of the masseter, and the terminal part can be felt, sir, with bidigital palpation and on the cheek of the same side.
Where you will feel it? If you have to feel it with a bidigital,
Yes, sir.
can you tell where you will feel it? Where you are going to put your two fingers?
Sir, along the anterior border of the masseter muscle, sir. After.
Yes, so that is one point.
Yes.
When you locate something, it has to be in the two, at least in two directions. Masseter is a big muscle, you know? It is almost occupying the whole of the face. So where you are going to feel that?
On the, sir, line of the line joining the tragus and the angle of the mandible, on that line, sir, at the anterior border, we will check.
You just say just below the zygomatic arch. Okay, you will feel at the anterior border of the masseter, just below the zygomatic arch.
Yes. Yes.
And this will be corresponding to which tooth?
Sir,
That opening is, yeah.
second molar tooth, upper second molar.
Second molar tooth, right. Did you look for the curtain sign here?
Yes, sir. The curtain sign actually restricts the mobility of the parotid gland above the zygomatic arch due to the attachment of the deep cervical fascia, sir.
Okay. Dr. Shenoy, you want to ask him?
Yeah, Omkar, just keep this slide inspection.
Yes.
You have written there posteriorly 2 centimeter behind the ear lobule. Just add one word there. Swelling is occupying also the retromandibular space. In other words, retromandibular groove is obliterated. That word should.
Yes.
If
Yes.
you see, if you go behind and put your hand between the mastoid process and the angle of the mandible, all of us have got that space. So this is the point which will help you later to say that this is parotid.
Yes.
You already swelling in front, below, and behind. So that is one other point. Okay. And hello. You have just
Actually, you stand behind the patient. Upkar,
Yes, sir.
from both the ear lobules, you know whether the lobule is lifted. So sometimes the patient will have uplifted ear lobule.
Yes.
Retromandibular groove obliteration is also seen best.
Yes.
You said curtain sign. What is that due to?
Sir, due to the deep cervical fascia, the superficial lamina, which gets inserted on the zygomatic arch, so it restricts the mobility of the gland in vertical direction above that zygomatic arch.
It divides into two. Gets attached. What happens to the deep part?
Sorry, sir.
The investing layer wraps the gland
Yes.
and divides into two.
Yes.
There's the one which is superficial joint. The fourth. Deeper one forms the stylomandibular.
Stylomandibular ligament, sir.
Yes. Divides into two. One is gets attached to zygomatic arch.
Yes.
The other one forms the stylomandibular.
Yes.
How do you look for the plane of the swelling in this? How do you look for the plane of swelling in this one? So you should know whether it's deep or deep to the deep cervical fascia or superficial. Sir, welcome, Javagar sir. Welcome.
Sir, by checking the mobility, like curtain sign also tells us that it is superficial.
If you have a small swelling in front of the ear, it could be a preauricular lymph node or a parotid. The preauricular lymph node is superficial.
Yes.
Most of the parotid is deep.
Yes.
Muscles you can contract, but fascia you have to stretch. So you stretch the deep cervical fascia by asking the patient to open the mouth wide.
Yes.
swelling will become less prominent.
Yes.
So always any swelling, the plane of the swelling is important. Okay.
Yes.
Add on one more small here. You just say that what is that? Your return surface is the regular. I think let us not avoid. Let us avoid all this smooth, irregular, not regular. Don't get into complicated. So,
Okay.
what do you understand by regular? Hello.
I should have rephrased
Omkar?
smooth, sir. Actually,
Yeah, smooth.
rephrase
We
it.
all understand. But is this the classical surface of the pleomorphic adenoma of 6 years duration? Surface smooth.
Yes, sir. I'll rephrase
Is
it.
it the classical? No, no. I agree. Pleomorphic adenoma.
Yes, sir.
Some kind of a nodular surface. You understand?
The
Usually.
lobulated surface is most.
Yes. So, but anyway, whatever we are seeing, we should say it's a male
Yes.
pattern, smooth surface. Okay.
Yes.
Surface appears smooth. Then comes your borders. You have to say. See,
Yes.
undergraduate, postgraduate presentation, not much of a day. It's the same principles.
Yes.
Location, extent, size, shape, surface, border, skin over the swelling. This is how you should present it.
Yes.
Surrounding area. Then you have some negative points, maybe dilated veins, puckering of the skin, pulsations, all that.
Yes.
Yes,
Yeah.
please take over, sir.
Yes, sir. Ever, sir, any questions?
Thank you, sir. Sorry if I joined late. Continue, sir. I'll join a little later.
Go to the next slide, sir. Yes. Santosh,
What are the tests, Dr. Omgar? What are
Sorry,
the
sir,
tests
yes.
you have done? What are the tests you have done to detect any facial nerve weakness?
Sir, examined for frowning, then examined for the for the buccinator muscle, like for whistling, we can examine. Then we can see the wrinkles on the forehead for testing the frontal belly of occipitofrontalis.
Okay.
And sir, the prominent nasolabial folds also. Then drooling of saliva, like deviation of the angle of the mouth can be also seen.
when I said you can frame it, you start from above, wrinkling of forehead, closure of the eyelids,
Yes.
nasolabial fold, then vaccinator, then orbicular
Angle
artery.
of
Some people will add the platypus side.
platism. Yes.
You commit, you remember like this. If you said here, then you went up. Okay.
Yes.
And that's what Professor Santosh wanted.
Yes.
What do you mean by no other spelling noted in the
Sir, to rule out any cervical lymphadenopathy which can be present along with this, I had examined the cervical loop of
that
lymph.
you could have mentioned separately after both the lobes normal, right lobe normal, the examination of cervical lymph node normally.
Okay.
Yes, sir. Next slide.
What about oral cavity inspection?
Sir, I've mentioned it separately ahead.
Okay. Okay. Anything else? Okay. Okay. Fine.
Yeah, next slide. Keep on. Move to go.
Next slide, sir.
Yes.
Go to the next. Yes. Sir, Jawahar sir, Santosh sir, you can take over.
Under investigation, he has said the FNAC first. Normally, we teach that we do non-investigatory first, no? What, Mr. Joshi?
Yes, sir.
So to classify it as invasive and non-invasive, we will prefer to do non-invasive first. Why?
Yes, sir.
Why?
Sir, just to confirm from where the swelling is arising from, the origin of the swelling can.
Why do you want to differ or put later the invasive procedures like FNAC or any other thing?
Yes, mentioned it, sir. USG, then last FNAC, but
Yes, sir. First, sir, USG we will do from where the swelling is arising from, and then to establish a pathological diagnosis, we will go ahead with FNAC after the USG is done, sir.
After USG, you have to go to CT, no? Only after planning surgery, you have to do FNAC or biopsy. Are they do frequently in Parotid?
Sorry, sir.
No, are they doing frequently FNAC and biopsy in parotid swelling?
What is the role of FNAC in parotid swelling?
To determine, sir, if it is a benign parotid, like pathological diagnosis to determine if it is a parotid swelling, and if any malignancy is there, then we have to go ahead with our more radical approach for management.
Omkar, this swelling is of the left side or right side?
Left side.
But in one of your slides, you have written left side is normal. Go to the previous slide. Previous one. Left parotid region is normal with no swelling palpable.
Again, there are
Mistakes.
lot of English mistakes are also there. I thought I will tell you later.
Sorry, sir. Yes.
And Omkar, in addition to that, just show the diagnosis. Always learn to give a diagnosis not like this in the exam. Show the diagnosis. You don't say that benign swelling arising from without evidence. This benign means what? There's no evidence. So don't get it complicated. Just straightforward. If you say 6 years duration, so what's your diagnosis? Diagnosis? Say most probably. That's what we say, no? Working diagnosis. All right.
Yes, sir. Yes, sir.
So straight away you can say, you only have told that ear lobule is raised and retromandibular, all that thing. So straight away you can tell here that's parotid tumor. Okay, that's how you give a diagnosis. Then let the examiner ask you 6 years duration. What do you think most probable parotid tumor? 6 years duration. Obviously, you don't have to say now when you return benign. Next time you return surrounding structure invasion is not there. So all these are not required. Like right electrical mass. What's your diagnosis? We don't say that because it is a benign ileocecal tuberculosis, because no evidence of malignant like that. You straight away tell carcinoma cecum or ileocecal tuberculosis like that. Let examiner ask you why benign.
Diagnosis is what you write in your discharge case summary.
Yes.
The diagnosis.
Yes.
It is at the end of treatment. This is the working diagnosis, whatever you are clinically suspecting.
Okay. Yes.
Yes.
Do you want to give a differential diagnosis? Or you are so sure that it is only the benign parotid tumor?
Sir, given the situation and the benign nature of the swelling light, in 6 years it has not progressed much, and it has not associated with any other symptoms. So mostly it is a benign pleomorphic adenoma, sir.
So you do not want to keep any differential diagnosis here.
No, sir.
Even the lymph nodes you do not want to keep there. There is a mass is there.
Sir, lymph node, sir, will not. The duration, sir, is a bit too much for lymph node. Will not be there for around 6 years. So probably, sir, lymph node is not what comes to my mind if I look at it for the duration, sir.
So if I say it's the parotid cyst is there, 6-year duration, and it's a parotid cyst. Your objections to that?
Sir, cystic nature can be felt on the palpation of the gland, and so From there, we can rule out. Here, the gland was firm in consistency.
Do you know what is that? Page's test in the thyroid? What is that? Cystic swelling feels form and form swelling feels other way. The same thing can be here also. So it is not necessary because it's encased in a capsule.
Yes.
So you won't be able to know the cystic nature of that, you know. So I just want to say that you are right in making a diagnosis, but do not be 100% sure about that. So if the examiner asks you that if there is any differential diagnosis, so always a second diagnosis to the parotid is the lymph nodes here.
Lymph nodes. Yes.
So at least you must mention that you are not blinded by all the things. You know, if you say it is that, it means you know the FNAC report of that, you know the CT if it has been done, you know about that. So examiner will think in that way.
Okay.
Okay, so always keep at least one or two differential diagnosis for anything which is there. If it's a cleft lip is there, it is a cleft lip. You know? There is no differential diagnosis for that.
Yes.
But any swelling which is there will always have a differential diagnosis.
Yes.
Okay, right.
Or you can say most 80% of the parotid swellings are benign, and out of that 80% are pleomorphic edema. Most probably it is a benign parotid tumor. This is what you can say, but still you cannot 100% rule it out.
Yes.
So you know rule of 80? What is rule of 80?
Sir, 80% of the salivary gland swellings involve the parotid gland, of which 80% are benign, and 80% of them are pleomorphic adenomas, sir, present in parotid.
So you have to tell about 20% which is left over. What are those swellings which are there?
Sir, they can be malignant swellings, which generally involve the submandibular and sublingual and minor salivary glands.
What
So
are
if
they?
it's no, what are the various benign tumors of the parotid? One you said is a pleomorphic adenoma. Can there be any other benign tumors of the parotid?
Sir, Warthin's tumor can be there.
Okay.
We
Any-
have hemangiomas and lymphomas, which can be there.
Lymphoma is not a benign one, no?
Sorry, sir, hemangioma, sir.
Hemangioma is there. And if it is a pleomorphic, then there has to be something other morphic.
So monomorphic, or that is adenolymphoma, sir, which is Warthin's tumor.
So monomorphic or adenolymphoma, yes. Right. So those has to come as a differential diagnosis.
Yes.
Oncocytomas.
Yes.
Okay. So keeping this working diagnosis, what was your first investigation for making the diagnosis?
Sir, firstly, I would like to go ahead with USG to confirm from where the swelling is arising from. So first investigation would be, sir, ultrasonography.
So what information you are going to get from the ultrasound in a case of parotid swelling?
Sir, first of all, the site of the swelling will be delineated. Then if there is the involvement of superficial or deep lobe, like the third dimension, we'll be able to see with ultrasonography if there's deeper extension and in relation to the retromandibular vein, sir.
So when you're doing the ultrasound for this patient, what will be the frequency of the probe you are going to use?
Sir, we will use, sir, high frequency. I'm not sure about the numbers, sir, since it is a superficial swelling. High frequency can be used, as not much deeper penetration is not needed, sir.
When you do abdominal ultrasound, what is the frequency of the probe? You want to see the gallbladder.
Yes.
What will be the frequency of the probe?
So 5 to 10 megahertz, sir.
10 megahertz is too high, isn't it? 3.5 to 5 megahertz.
Okay.
Okay. And when you have to look for the breast or thyroid?
Not aware, sir.
It's around 10 to 12 megahertz. So same frequency probe will be used here also in the parotid also. Okay,
Yes.
right.
What else can you get information you'd get on ultrasound? One is
Sir,
height. Then
sir, then if there is any associated lymph nodes in the region.
first of the tumor itself, echogenicity,
Yes, sir.
right?
Yes, sir.
Whether there are solid cystic areas or not, to
Yes,
know
sir.
whether it is pleomorphic.
Yes.
Is it mandatory to go for CT scan and MRI?
Sir,
When
to
USG shows and clinical examination tells you that there is no deep lobe involvement and there are no nodes.
sir, CT scan will help in planning
My
the.
question is it mandatory to go for
Sir,
CT
no, it
scan?
is not mandatory, sir.
Yes, good. CT
It is
and
not
MRI or only one thing, and preferably which investigation, if at all you do? CT, MR. Both or only one, and which if it is one?
Sir, CT scan would be better delineate, sir.
MRI use actually, but depending upon the surgeon's choice, whatever he is comfortable to read with, if he is reading on his own. Why it is so? If you find that on sonography it is benign, but it may turn out malignancy. Why still we don't need CT scan or MRI?
Sir, the
In this case,
uh,
that is not mandatory.
the treatment would be still, sir, superficial parotidectomy.
Yes. Yes.
So will you like to do the FNAC in this patient or not?
Sir, yes, sir. To confirm the pathological diagnosis, we would like to go ahead, sir, with FNAC.
So is it always 100% or it's a debatable thing? Because the minimum surgery you are going to do in this patient is?
Superficial parotidectomy, sir.
So that is why FNAC is in debate. Some people may not agree with going for the FNAC in this patient. Okay, but majority will do the FNAC to know that what type of the tumor it is.
Yes.
Then what you are not going to do the CT or MRI in this patient? Yes, you said you are not going to do that because there is no deep involvement is there. There is no facial involvement is there. It's a mobile tumor, so you are not going to do that. So what is the plan of treatment now?
Any role of core needle biopsy?
Sir, in some cystic swelling like adenoid cystic carcinoma, if the FNAC might just miss if some cystic area is needed, so core biopsy in that cases, sir, will help.
It is not to be done. Why? There are few reasons for not doing it. Even FNAC is not mandatory because mostly it may not, a negative does not rule out malignancy, and most pathologists are not, it is not that common that all cytologists will be reporting malignancy. They also know that 80% are benign, 80% are pleomorphic, right? So it is true cut core needle is not done because there are chances of damaging nerve, theoretical, creating fistula, and some tumor, you are breaking the capsule if it is there in the smaller malignant tumor. So it is not to be done.
Yes.
Khanna sir, please.
Okay, so what is your plan now?
Sir, I will go ahead with pre-anesthetic workup, and after that, sir, we'll post the patient for surgery to be done. As superficial parotidectomy is to be done in this case, sir.
So how you are going to counsel this patient for superficial parotidectomy?
Sir, we will explain them about the surgical procedure and the associated risks with that, which includes, sir, some facial nerve injuries which can be happening in the surgery, and we will explain them some chances of Fraze syndrome which can happen post-surgery, and we will also explain some possibilities of, sir, parotid fistula. So all these complications will be explained to the patient before.
Okay. So you have taken the patient on the table for the superficial parotidectomy. Now prepare this patient on table.
Yes.
Patient has come on the table. Proceed about that now. You are planning to do a superficial parotidectomy.
Sir, we will first play, once the patient is on table, we will tilt the neck to the opposite side to make it more prominent, use the head rings. Then we will mark the incision.
You don't want to anesthetize the patient? Patient has come on the table.
Sir, yes,
I'm asking you proceed now. Yeah.
So the anesthesia team will first give the general anesthesia to the patient.
Yes.
After that,
Then
then
what
we
comes?
will.
Then what comes next? Position.
Sir, position of the patient, sir, we will put two head rings below the head and tilt the patient's head to the opposite side.
Still more? Anything more?
And extend the neck, sir.
Any head and neck surgery?
Sir, Trendelin.
Reverse Trendelenburg.
Reverse Trendelenburg position, sir.
How much?
How much?
Sir, 30 degrees, sir.
It is
15.
15.
15.
1-5.
15 degrees.
Okay.
Now drape the patient.
Yes.
Yes, sir. Sir, then after draping the patient, sir, we will.
No. You have to tell me. You have to tell me. What
Sir, sir, triangular drapes will be used for the patients to cover the head area. And sir, the exposure will be from the entire ear to the clavicle.
Anteriorly?
Anteriorly, sir, till the mentum, sir. We will expose.
Mentum means?
Sir, the chin, sir.
What you want to keep
See.
exposed? What
Sir,
thing you want to keep exposed on the media? That is the most important part of the draping.
Sir, facial nerve injuries, or if we are using facial.
What part you want to see? Two landmarks.
Sir, angle of the mouth we would like to see.
And
sir,
external canthus of the eye. Cotton plug in the auditory canal.
yes. Yes.
Sterile cotton plug.
Yes.
What is this technique, draping technique called as? What is the name of this draping technique?
I'm not aware of the name, sir.
It's called a Hopsley technique.
Oh.
Hopsley technique. Okay.
Okay.
Right.
Sir. Okay.
Now so you have draped it. Make an incision now.
Sir,
And what is that incision you are going to make?
Sir, Lazius or modified Blair's incision, sir.
Okay. What is that?
Sir, it extends from the tragus, which goes below the ear lobule and till the mastoid and comes 2 centimeters below the mandible, parallel to it.
You know, whenever you have to make any incision, it has to be at least in two directions. You have to tell. If you say in front of the tragus, it may be zygomatic arch may be there, or even the right side of the nose may be there. That is in front of tragus. So where exactly you are going to put the incision?
Sir, just 1 centimeter in front of the tragus.
1 centimeter. What is the purpose of putting that incision?
Sir,
It's a cosmetic incision. It has to be hidden in that area. So if you're going to put a 1 centimeter in front of the tragus, it will be very obvious incision, it will be there. So you have to be very near to the tragus, you know, in the millimeters, not in centimeters. Okay, right.
Yes.
And why 2 centimeter below the arch of the mandible? You said it is 2 centimeter below the arch of the mandible. Why is that? I said just make it 1 centimeter or make it 4 centimeters. Why 2 centimeters?
Sir, the marginal mandibular, sir, runs along the lower border of the mandible, sir.
So if you make a higher incision, you are more likely to damage the marginal branch of the mandibular nerve. Okay.
Yes.
Okay. Okay. So proceed with the incision now. How will you raise the flaps?
Sir, anteriorly, sir, the flap is raised to the anterior border of the parotid gland. Posteriorly, sir, the flap is raised till the mastoid process, which exposes the entire parotid gland then, sir.
Will you like to raise a thin flap or thick flap?
Sir, thicker flap is generally preferred.
Why?
Sir, because in post-op, there will be chances of Frey syndrome developing will be more in cases of thinner flap.
Right. Okay.
Yes.
You
So
should
you are-
avoid looking at the hair follicles on the posterior surface of screen flap. This is what one of the hint is, particularly in males where there are beard.
Okay.
It should be that thick.
Okay.
Okay. Then what you are going to do after that? You raise the flaps.
Then we will divide the, we will go deeper and divide the fascia overlying the parotid, which will expose the gland, sir. Superficial part of the gland will be exposed. After lifting the gland with care, sir, we will avoid doing injury to the facial nerve, the branches of the facial nerve and the retromandibular vein which lies in the bed.
So how will you do that? That is the crux.
How to identify the facial trunk before lifting the parotid? You have to identify first the facial nerve. What are the points to identify?
Sir, facial nerve, sir, can be identified at the inferior margin, like the Conley's tragal pointer is one landmark where we can see the facial nerve. Then the facial nerve lies just superficial to the striate processor, and it is there below the squamotympanic fissure.
Any other points? There are more than 6 points to identify the trunk. Anything to do with temporomastoid process or suture?
Whatever, sir.
Some book says you can trace retrograde from the branches to the trunk.
Yes.
The last one is by electrical stimulation.
Yes.
Here you have to identify the nerve first, then do the dissection. Not like thyroid.
You know what is that retrograde technique called as? When you are tracing the branches and coming to the main trunk.
Name I'm not aware, sir. Name.
Hamilton Bailey technique.
Hamilton Bailey. Okay.
But sir, he himself was not following. He said it's a wrong procedure. He discovered it, but he has condemned the procedure, sir. That's what is given in books. Not for, sorry to contradiction this.
Maybe in case of inadequately done recurrent.
Yes, sir.
Okay.
Karnagwal has given 10 minutes more. Sir.
Right.
Yes, sir asked for Omkar, how do you identify? You said, right. What is the next step? After identifying, what do you do?
Sir, we will dissect off the parotid from the facial nerve. Facial lobe of the facial, superficial part of the parotid gland will be dissected from the facial nerve.
How do you dissect it? Which forceps you use to dissect? Which instrument I'm asking?
Sir, mosquito forceps, sir.
Mosquito forceps. Turned down or turned up?
Sir, turned down, sir. Sorry, turned up, sir.
Already you will have neuropraxias. So you just call you would lift it, let's tunnel it, lift it and cut.
Yes.
Right. Please, sir, Jawahar sir, Santosh sir, please.
When you parotidectomy, there is an accidental injury to the branches of the facial nerve. What do you want to do?
Sir, we can use sir nerve graft, sir, if on table it is noticed.
From where?
Sir, greater auricular nerve can be used since it is available local, and or sural nerves can be used, sir.
Okay.
What is that graft called? It's called the cable graft.
Cable graft, sir. Cable graft.
Omkar.
Yes, sir.
Yes, Dr.
If
Karnal,
the
sir,
deep
good
lobe
evening.
is involved, good evening, sir. If the deep lobe is involved, what could be your plan of surgery?
Sir, if deep lobe is involved, sir, we have to go ahead with the total parotidectomy, sir. So it can be done by two approaches: either total conservative, in which we spare the facial nerve, and or total radical. But here, sir, total conservative will do since it is a benign swelling, sir. So total conservative parotidectomy will be the approach, sir, in that case.
So how will you
Is
remove
there any
the
specific
deep
step? Sir, go ahead, sir, please. Sir.
No, yeah, you can go ahead, Dr. Karnakaran, you can ask. Yeah.
See, whenever you do a total parotidectomy, or whenever you want to remove the deep lobe of the parotid gland, you have to take a precaution. The single most important precaution in removing the deep lobe. What is that?
Should not damage the retromandibular vein, sir.
Omkar, what is Patty's
Have
plane?
you ever seen?
What is Patty's plane?
Sir, the fasciovenous plane of Patty, sir, divides into superficial and deep lobes of parotid.
Yes.
So,
and how is the arrangement of the structures there? What are the structures which come in that plane?
sir, the retromandibular vein is one structure. Then, sir, the facial nerve with its branches, it arises in that plane.
Yes. And?
And sir, deep to it, sir, ninth and 10th cranial, 9th and 11th cranial.
Usually most of the planes which are there has to be three structures: vein, artery, and nerve.
Yes, sir.
So how is the arrangement? Which artery, which nerve, which vein?
Sir, vein is the retromandibular vein. So artery, it is a bifurcation of the external carotid into the.
No, Omkar. Retromandibular vein, correct. Yes, you said. How is it formed?
Sir, retromandibular vein is formed by the superficial temporal and the maxillary artery. Maxillary, sorry, veins. Sorry.
Yes.
And,
carotid. The external carotid divides into the terminal branch.
Yes, sir,
the external carotid doesn't bifurcate.
Okay, sir. Terminal branches of external carotid.
Yeah. So if you see torrential bleeding, means your dissection has gone deep.
Yes, sir.
So you should be very careful. Now you answered Dr. Karnakaran's question. Sir, you can give the answer.
Yes, almost. The point is you have to dissect the neck and get control of the external carotid artery.
Yes.
You have to put an umbilical tape around the external carotid artery before you operate on the deep lobe of the parotid. Because the terminal branch which passes through it divides into maxillary artery and superficial temporal artery. If you injure, there may be a torrential bleeding and you could not control it, and it may lead to chaos and a lot of problems may occur. When you have a proximal control, you can put a vascular clamp and just find out from where it is bleeding, and you can get it controlled. Even if you are not able to control, you can ligate the external carotid artery, which does not produce much harm.
Yes.
Dr. Omkar, even after
Yes.
doing superficial parotidectomy, if you have facial palsy in the postoperative state, what will you suspect and how will you manage it?
Sir, post-operatively, sir, we will look for any signs of facial neuropathy like incomplete closure of the eyes, deviation of the angle of the mouth, that is there, sir, we will first reassure the patient. We will give him, sir, immediate post-op period, we can give him, sir, steroids. And then, sir,
there will be a neuropraxia for up to 6 weeks, okay?
Yes, sir.
So you have to reassure one.
Yes.
The next answer is question. How will, if there is neuropraxia in the post-operative period, how will you manage it? Yeah, you started a well.
So steroids, sir, immediate post-operative period, so steroids can be given.
How long you will give to differentiate it from real injury?
We can continue till 4 weeks, sir. After that, the real injury will be still persisting. If it is transaction or if it is more than neuropraxia, it will still persist after 6 weeks, sir.
Okay, okay.
How do you classify the facial injury? Do you know any grading system for that?
Broadweight system, I think, sir.
No, there is a separate grading system. You read. Yes, we are running short of time.
It is House Brackman system, which is there. You must read that, okay?
Okay.
And in the fasciovenous plane of the Parotid, which is there, the nerve is superficial, vein is in between, and artery is the deeper one. Okay, so that is the plane of arrangement in the fasciovenous plane. I think, Dr. Srinivasan, can we stop now? We can go to the next case.
Yes, sir. Yes, sir. Kanavel, sir.
Yes, sir.
Do you expect any recurrence in this case?
After superficial parotidectomy, sir, chance of recurrence are very less. But since this tumor has pseudopods, sir, it cannot be ruled out completely, sir.
Can you predict with any investigation?
Imaging can be done, sir, after 6 months or years, sir.
Follow. Your meaning follow.
No, sir is asking immediate post-operative period. Is that your question, sir?
Yes, sir.
Sir, you can give the answer, sir, because
some books say you can estimate the
IHC markers are there, sir.
markers are there.
Yeah,
Like
some IHC markers are there. Even
DFT and MUC1, they say. But though we are not doing it frequently, but still these people have to know PGs.
There are some markers which you have to look for if you suspect. Okay.
Yes,
sir.
So the causes of recurrence is one is spilling, number two is pseudopods, and three is inadequate
clearance
removal of the superficial lobe. So that's why you'll get a recurrent pleomorphic adenoma. These are the causes. Okay.
Yes.
Dr. Omgar,
Yes,
how will you classify parotid fistula and how will you manage post-op fistula?
Sir, parotid fistula, sir, also needs, sir, just first the reassuring the patient.
Classification,
Classifications are not aware of.
Is a ductal fistula or a glandular fistula?
Yes, sir. So
now you tell how do you manage that?
Sir, glandular fistulas need to be self-limiting, but ductal fistulas need to be repaired, sir. Mostly there are chances of glandular fistulas which are seen more commonly. So we have to just reassure the patient in that case and avoid him. We have to tell him to avoid citrus fruits, which will elicit more of the salivary secretions. So it will just self-limit on its own, sir.
Which drug you can use to decrease secretions?
Sir, anticholinergic, sir, and antiperspirants for the skin care, sir.
Okay. Suppose there is a stenosis of the opening of the duct producing fistula. With the fistula, when you do a fistulogram, how will you manage it?
sir, we can do, sir, endoscopic dilatation of that opening, sir, which will then help in drainage of the secretions which are getting pulled up and causing it to come out of the fistula, sir. Then the fistula, sir, on its own will get limited if we provide a separate drainage.
Okay, that's some papillotomy like techniques.
Yes,
Okay.
sir.
Can we go to the next case, Santosh?
Yes, sir. Yes, sir. Okay, sure.
Kanavel, sir. Omkar, you would like to ask any doubts, clear any doubts?
So, sir, got very much of information, sir. In
Okay,
this.
okay. Thank you.
Thank you, sir.
Thank you, Dr. Omkar. Give our
Thank you,
thanks
sir.
to Professor Rege sir and Shilpa ma'am for permitting you to present a case here. You can stay
Yes.
with us for the next case. Dr.
Yes.
Ashia, good evening.
Good evening, sir.
Welcome, Dr. Ashia. Dr. Ashia is a postgraduate from Saptagiri Institute of Medical Sciences and Research, Bangalore. She will be presenting the next case, and she is kindly contributed by Professor Kalaivani ma'am from Saptagiri Institute of Medical Sciences. Good luck, Dr. Ashia.
Thank you, sir. Good evening, respected teachers. I'm presenting the case of 38-year-old male who is Dada Pir. He's a mechanic by occupation and neck since 1 year and pain in the swelling since 15 days with complaint of palpitation since 15 days. Elaborating his history, patient was apparently normal 1 year ago. Then he noticed a swelling in front of neck, which increased in size since 15 days, which is associated with pain, insidious in onset, progressive in nature, dull aching type of pain, present throughout the day with no aggravating factors, reduces on taking medication. He also complains of palpitation since 15 days, present throughout the day. He complains of agitation, restlessness, nervousness since 6 months and is passing loose stools since 6 months with 7 to 8 episodes per day. And there's also history of intolerance to heat, increased sweating from 6 months. There's history of tremors on doing daily routine activities since 6 months. There's also history of generalized body pain since 6 months. And there is no history of difficulty in breathing, no history of alteration of voice. Coming to the treatment history, patient is on anti-thyroid drugs and beta blockers from past 15 days. Past history is not significant. Family history is nothing significant. Personal history, patient is predominantly vegetarian with appetite increased in 6 months and sleep is disturbed from past 6 months. Bladder is normal, bowel increased bowel movements from 6 months and is a chronic smoker since 14 years. Local examination, general physical examination.
Wait,
Yeah.
ma.
Yes, sir.
Wait, doctor. Wait, doctor. Let the examiners take.
So can you go to the first slide? Go to the first slide.
Yes, sir.
Why did you write the name of this patient?
Mm.
Have you ever seen in any presentation where the name of the patient is written?
No, sir.
Okay, so from the next time, do not write the name of the patient.
Yes,
No,
sir.
you cannot disclose the identity of the patient. No?
Okay, sir.
That is against the ethics. Okay, go to the next slide. Right. So there is swelling in the front of the neck. Since is not a good word, you know. What should be used here?
The past.
No. In place of since, what word should be used?
From.
For, you know.
For 1 year.
Okay, if you are sure about the things, exactly from 365 days this was there, then you can say since.
Okay, sir.
Okay, but if it is just you say 1 year or like 15 days, then in that case it is always for, you know. So swelling in front of the neck for 1 year, pain in the swelling for 15 days, and palpitation for 15 days. Okay.
Yes.
So if there's a swelling in the front of the neck for 1 year is there, pain for 15 days and palpitation for 15 days, what does that indicate? Only based on these chief complaints.
Oh. So it indicates a patient is in a toxic state, sir. Toxic features are there. Indicating of hyperthyroidism features, sir. With goiter, sir.
What
Why?
type of hypothyroidism? When you said swelling for 1 year and palpitation for 15 days, what type of hypothyroidism?
Sir, primary thyrotoxicosis, sir.
Is it so?
Yes, sir.
In primary thyrotoxicosis, swelling and hyperfunction feature appear at the same time.
No, sir. Secondary, sir. Sorry, sir. Secondary hyperthyrotoxicosis, sir. First, the swelling appears, then the symptoms appear, sir, in secondary.
That's what your complaints indicates.
Yes, sir. Yes, sir.
Sorry, sir. Jay, sir. Sorry to interrupt. Continue, sir.
Okay. What is the age of this patient?
38, sir.
Okay. So 38 years, the patient had 1 year swelling on the neck was there.
Yes, sir.
So is that a good age for developing the secondary hyperthyroidism?
No, sir.
What is the difference between a hyperthyroidism and thyrotoxicosis?
So thyrotoxicosis, it's both biochemical and physical findings, sir. Whereas hyperthyroidism, it consists of physical features, sir. More of physiological features.
If some patient has got the high T3 and high T4, will that be a hyperthyroidism or will that be thyrotoxicosis?
Thyrotoxicosis, sir.
Usually, thyroid is based on the thyroid hormone level.
Yes, sir.
It's just like somebody is having the AIDS and HIV. So HIV is the virus which is there and AIDS is the manifestation of that. Similarly, here also, if there's a biochemical one is there, it may be hyper or hypo, but manifestation of that will be the thyrotoxicosis here. Okay, yeah. Go ahead to the next slide here. Next slide. So, which increase in size since, so why they should be increased in size in 15 days time?
So
Which thyroid swelling will cause a increase in the size in 15 days time?
Sir, hemorrhage in the nodule, sir.
Hemorrhage.
Does
the hemorrhage causes
அதுல இருந்து ஒரு பேஷண்ட் வந்து தஞ்சாவூர் பேஷண்ட் ஷீஸ் வந்து டயபெட்டிக் ஹைப்பர்டென்சிவ் பிராங்கியல் ஆஸ்மா ஸ்மோக் இருக்கா கொசுக்கா இன்னைக்கு அடிக்கலையா அவங்க வீக்லி 2 days அடிக்க சொன்னேன்.
May I request Dean VMCC to, yeah, okay.
Sir, muted, sir. Muted, sir.
Okay, yeah. So, 15 days time, is it a sudden increase or a rapid increase?
Sir, sudden increase, sir.
No, sudden usually occur in a day or so all of a sudden the patient gets up in the night and the swelling is increased in size because of the hemorrhage inside that. Well, rapid one may suggest that the patient might be developing the malignancy. Okay, so that is the difference in the rapid and the sudden. And then you say it's insidious in onset, progressive in nature, dull aching present throughout the day, no aggravating factor, reduces on taking medication. So which swelling can reduce on medication?
That was regarding pain I had mentioned, sir.
Not the swelling, is it?
No, sir.
Regarding the pain, it's okay. Yeah. Why agitation, restlessness, nervousness since 6 months you are telling, and other place you are saying it's the 15 days.
Few complaints he started from 6 months, sir. Then few complaints he started from 15 days, which was troublesome for him. So he seek medical attention, sir.
Can you again go to the chief complaints? So here you are only saying palpitation since 15 days. But
Yes.
if you look at the history here, can you go to the next slide? It's all from 6 months. The history of agitation is there, restlessness is there, nervousness, increased loose stools, intolerance to heat, all from 6 months.
Yes, sir.
Do you think it is not important?
Yes, sir, that's important, sir. The main complaint which for which he seeked hospital, I mentioned, sir.
But all these features, they suggest the patient is having the toxic features.
Yes, sir. Yes, sir.
So it's not 15 days, it is almost for 6 months the patient is having all those things. Okay, next slide. Why the generalized body pain?
Sir, because in the hyper metabolic state, sir, there will be protein catabolism will be there, sir, which will cause the generalized body ache, sir.
Patient is on anti-thyroid drugs and beta blockers also. Both things are, the patient is continuing.
Yes, sir.
What are the usual indication of giving the beta blockers?
Sir, if patient is having tremors or palpitations, sir.
But that will be controlled by the anti-thyroid drugs.
Yeah, sir. Tachycardia, sir.
No, when you give the beta blockers to a patient who is a thyrotoxic patient.
Yes, sir.
Is it a routine thing to give the beta blockers in all cases of thyrotoxicosis?
Yeah, sir, it is routinely given, sir.
No, it is not routinely given. No? Anti-thyroid drugs are routinely given. But beta blockers are given usually when you are preparing the patient for the surgery. So you can give it 7 to 10 days before that. Not as a for the preparation of that. Preparation is done by the anti-thyroid drugs. And then in case all of a sudden the patient of the thyroid storm is there, then there is indication for giving the beta blockers. Okay, so it is not given as a routine to every patient of thyrotoxicosis. Routinely you give the anti-thyroid drugs. And if you are preparing for the surgery for this patient, at that time, in about 7 to 10 days time, you will start the patient on the beta blockers. Okay.
Yes, sir.
Go to the next slide. Family history. Why did you ask for the family history? Nothing significant?
Yes, sir. Any other family members showing the similar complaints, sir, indicating the presence of autoimmune disease, sir?
Do you think it is only the family which is important in a thyroid case?
Yes, sir.
The surrounding person staying in that area.
Yes, sir. The endemicity, that also matters.
So that has to be always taken into account. Endemicity of the goiter, and that has to be taken into account.
Yes, sir.
Okay, next slide. So, bowel movements. In what type of the bowel movements you have asked about that?
He's having loose stools, sir. Increased bowel. Loose stools.
Loose stools. So, when the patient is having loose stools, what are the things you are going to ask?
History of loss of weight, sir.
No, in the stools. What are the things you are going to ask in the stools?
Consistency, sir. Then blood tinged.
Yes.
And then frequency, sir.
Okay. So what frequency you are more interested in a case of a pathological loose stools? You understand that?
Yes, sir. Yes.
The daytime or the night time?
Mm.
Maybe it's the night frequency, that is a what is called a red flag sign which is there. That is the night frequency of the stool which is there. The patient may say that I have to get up in the night 2 times or 3 times or 4 times in the night.
Okay, sir.
So that is much more important than the day stool is also okay, but much more the night time. Okay. I think somebody else can take over. Yeah.
Go to history of presenting illness. Next slide. Should you not mention about pressure symptoms in this case? Huge swelling over the neck.
Yes, sir.
Will there be pressure symptoms or not? Should you not mention about it?
Yes, sir. I have mentioned, sir. No issue of difficulty in breathing, no issue of alteration in the voice.
That's the only thing. Only 2 things you will get.
No issue of difficulty in swallowing.
All those things you have to mention, all those 5 features of compression.
Yes, sir.
Number 2, what about metastatic features? If it is going to be a malignancy case, that also come in the history of presenting illness. Then only it will be complete.
Yes, sir. Yes.
Number 2, you have written about treatment history. Should you not mention about goitrogenic drug intake? If the patient is hypertensive, diabetic, all those things you have to mention.
Yes, sir.
Then
Yes.
exposure to tuberculosis. You should mention separately about drug history in a case of thyroid. And the 4th one,
Yes.
you have not mentioned about any childhood irradiation to the neck.
Yes.
Is it not important?
Yes, sir. Yes, sir.
Which is the condition they will give childhood irradiation? What condition?
Lymphoma, sir. Then treatment for tonsils, adenoids,
Thymoma?
thymoma.
All those things you have to rule out.
Yes, sir.
Rule out malignancy. Understand?
Yes, sir.
Don't use this word nothing significant in a family history. You must say no similar illness in the family or in the area.
Yes,
Which
sir.
condition produces a family history of goiter? What is it called?
Familial thyroid.
Familial? Be correct, complete.
Familial thyrotoxicosis.
Thyrotoxicosis. Familial disharmonigenesis. It is called familial disharmonigenesis. Understand what is the defect in that familial disease? These are all UG questions,
Yes.
Converting enzyme, there is a deficiency which runs in the family. All those things you have mentioned. Don't use the word nothing significant in any of your case presentation, and similarly don't use short forms, abbreviations.
Yes, sir.
Okay. Go to next slide. As I start told, there is a variation in your duration, where once you say 15 days, once you say 6 months, all those things should be correct in your presentation. Okay. Next slide. Sir Kanagal, sir, you want to add anything, sir?
No, sir, I am watching, sir. You please, you are the guest faculty, sir. Please take the discussion. Sir. I will be standing back.
Okay, my present.
General physical examination, sir. Here is a middle-aged male patient who is moderately built and nourished, conscious, cooperative, well-oriented to time, place, and person. His weight is 48 kgs and height being 172 centimeter with BMI of 16.2 kg per meter square. There is no pallor, icterus, or clubbing, or cyanosis, or lymphadenopathy or edema. His pulse rate is 104 beats per minute, tachycardic. And blood pressure is 140 by 90 millimeter of mercury measured on the right arm in supine position, and temperature is 98.6 Fahrenheit. In the head to toe examination, the Specific findings are the eye signs being the conjunctival congestion was present, and the skin it was warm and moist hands, sir. Only those specific findings were present, and local examination. So this is the
What about general examination? You will not look for something in the hands and tongue?
Yes, sir.
It comes in general examination, you know?
Yes, sir.
You haven't mentioned here.
It was not there, so I didn't mention.
You have to mention. What will you look for?
Tremors, sir. Fine tremors.
How to elicit?
Ask the patient to stretch his hands, sir, with the fingers apart, and place a pen or a paper over it, and wait for 30 seconds, sir. Then if there are tremors, then the pen or paper will start shaking, sir. That is for the fingertips. And for tongue, ask the patient to open the mouth and keep the tongue inside. If there are fine tremors, the tongue will start trembling, sir.
Any other name for tongue tremors?
Fasciculations.
Any other condition where you can get fasciculations in the tongue other than thyrotoxicosis? Have you heard of DT? Delirium tremens, Parkinsonism. All those things you have to keep in mind.
Yes, sir.
Okay. Go to next slide. No, your voice is muted.
Local examination. On inspection, there is a solitary.
Please develop the habit of telling in a format what is the position of the patient, what is the position of the examiner. After obtaining consent, that all those things are to be necessarily told in the exam. You cannot straight away go and open the area where you want to see.
Yes, sir. Yes,
Understand? It has to be complete. Don't think I will take it for granted.
Yes, sir. Yes, sir. Patient is made to sit comfortably on a stool, sir, with examiner sitting in front of the patient, sir, for inspection after taking the consent, exposing the neck on the upper thorax, sir. The patient has been examined in a well-lit room. So on inspection, there's a solitary shield-shaped swelling present in front
The
of
position of neck or head
neck being slightly flexed, sir.
flexed down.
Slightly.
On inspection, test to be slightly extended. Only on palpation you will flex.
Yes, sir. There's a solitary shield-shaped swelling present in front of neck, measuring approximately 10.
What do you mean by shield shape?
Like a butterfly shape.
Tension is butterfly. Okay.
Yes, sir. Measuring approximately.
That in the front of the neck in the region of thyroid.
Okay, sir.
Okay.
Yes, sir. Measuring approximately 10 cross 7 centimeter with the irregular surface and well defined.
Extent you are telling next. Okay.
Yes, sir.
Surface.
With the well-defined borders, the swelling is extending horizontally from the either side of the posterior border of sternocleidomastoid and vertically.
How much? 10 or 7?
Sir, horizontally is 10 centimeters, sir.
That you have to mention.
Yes, sir. Yes, sir.
Horizontally 10 centimeter, extending from. That way only you can tell.
Yes, sir. Horizontally, it's a 10 centimeter extending from the either side of the posterior border of sternocleidomastoid, and vertically it is 7 centimeter from the level of superior part of thyroid cartilage and inferiorly just above the sternal notch, and the swelling moves with the deglutition. Positive, sir. Then coming
they
to.
will ask you when you say movement on deglutition, why should it move? What are the other structures would move? How will you differentiate? All those things will be put in the examination.
Yes, sir.
Do you know about all those things?
Yes, sir.
Why does it move?
And
So because thyroid, it is covered posteriorly by the pretracheal fascia, which condenses to form the Berry's ligaments. It is attached to the
What anteriorly what ligament? What is the covering?
anterior by the investing layer of the deep cervical fascia. Sir.
Very good. What happens laterally?
Sorry, sir.
What happens laterally to that fascia?
So that will get condensed, sir, to form the Berry's ligament, sir.
Okay.
That is attached to the trachea, whereas the trachea, it is attached to the pharynx by the thyropharyngeus and cricopharyngeus. So as the
to trachea or something else? Berry's ligament.
It is attached to the pretracheal fascia. Sir.
Pretracheal fascia. Is she correct, sir? Karnagaran, sir.
Okay, sir. It condenses to form the Berry's ligament. Yes?
Yes, sir. Yes, sir.
Yes.
What are the other structure moves on deglutition?
Thyroglossal cyst, sir. Then pretracheal or prelaryngeal lymph nodes. Then subhyoid bursitis.
How to differentiate thyroglossal cyst from thyroid swelling?
Thyroglossal cyst, it will move on the protrusion of tongue, sir. Whereas the thyroid swelling, it will.
How will you test? How will you establish movement on tongue?
Yes,
movement
sir.
on tongue, protrusion of tongue.
Yes, sir. Ask the patient to open the mouth and so that the jaw gets fixed. Then ask the patient to protrude his tongue. Then we have to see the swelling if it is moving or not, sir.
You have to hold the swelling, then put out the tongue. Okay.
Yes.
Okay, go.
And
Go
then,
further.
yes. Coming to the palpatory findings.
Oh, madam, we stop here. Inspection, there are so many other findings are there. You must mention about the position of trachea.
Yes, sir. That palpation may I mention.
On inspection itself, you have to say what is the appearance of trachea, whether it is in the midline or deviated.
Yes, sir. Yes, sir.
Okay, if the lower border is not seen, what will you do?
In inspection, sir.
Inspection. We are in inspection.
We'll proceed with the Pemberton sign, sir.
Any other sign? What is the Pizzilus method about?
That is done in the case of short neck or in obese patients, sir, to visualize the thyroid region, sir, for inspection.
Region or lower border?
To enter swelling, to make it prominent, sir, we do that.
Which are the conditions where the lower border cannot be seen?
Okay, sir.
Which are the conditions where you cannot see the lower border?
Retrosternal.
The short neck. Only you said short neck.
Yes,
Any
sir.
other condition?
Then retrosternal goiter, sir. There we cannot see the lower border.
Say huge thyroid gland.
Okay.
Okay.
So the position of the trachea is normal, sir.
How will you find out on inspection that the position is in normal? You say it appears to be normal. Don't say it is in normal.
Yes, sir.
Don't say appears to be in midline, not normal.
Okay, sir.
How to find out? On inspection, how will you say the trachea is deviated or in the midline?
Yes, sir. If it was deviated, then there would be a prominent of the sternocleidomastoid where it is deviated, sir, which is called as trial signs.
Very good. Go further. No, the surface we said.
Yes, sir.
Previous slide. You said what did you say on the surface?
Irregular surface.
Call it irregular or bossulated?
If it is more prominent, then we can say bossulated, sir. So, that's why I.
Prominent, it is going to be smooth by appearance.
Sorry, sir.
No, if it is not prominent, it is going to appear smooth. It will not be regular or irregular on the surface. It is about borders.
Yes.
In that is also a regular, irregular border comes in an ulcer. In a swelling, you call it well-defined or ill-defined. You understand?
Yes, sir. Yes, sir.
Don't get confused. Don't mix the two things. Okay.
Yes.
Then what else on the inspection? You'll see.
Then
Swelling, you follow the rule of 5S. Size, shape, site, extent, surface over the swelling, and scars and sinuses. Here you have to mention about scars and sinuses. That indicates a previous surgery.
yes, sir.
Then also you mention about dilated veins. That was also an inspection.
Yes, sir. Yes, sir.
Huh? There's so many things you are bizarrely prepared. Are you exam going?
Yes, sir.
We correct. Go to next. Sir, you want to ask any question, Karunakaran sir? Karunakaran
No,
sir.
sir. Let her proceed. Let her proceed, sir.
Okay, sir.
Coming to the palpatory findings, there is a solitary butterfly-shaped swelling present in front of the neck, measuring 12 centimeter horizontally and 9 centimeter vertically, with nodular surface and well-defined borders, firm in consistency.
Madam, always tell about warmth and tenderness. First point. Any touching palpation, you already mentioned warmth and tenderness. That has got something to know whether there is inflammatory sign.
Yes, sir. Yes, sir.
Okay, any case. You may be sure of the diagnosis, but you have to mention. You think all the examiners are idiots. No, you have to give the information by your presentation. Okay.
Yes, sir.
Mention about
no local
warmth and tenderness in first.
Yes, sir.
Next, go to the infectory findings confirmation.
Yes, sir. Local rise of temperature, sir, and the swelling is a non-tender, sir. Then extent it is confirmed from the inspectory findings, sir. Then plane of the swelling is deep to deep fascia. Then position of the trachea is central in position, and carotid artery pulsations they are felt and in normal position, and no other swellings palpable, sir.
See, if there is a change in carotid artery pulsation, the site of carotid artery pulsation, what is the sign called?
Berry sign.
Pardon?
Berry sign.
You explain Berry sign.
Berry sign, there will be absent carotid artery pulsation, sir, because of the infiltration of the carotid sheath from the malignancy, sir. So we will not be able to feel the or palpate the carotid pulsations.
Even if the carotid pulsation is not felt in the right place, or it is displaced from that place, we can call it as a Berry sign. Okay.
Yes, sir. Yes, sir.
Okay.
Madam, from where did you palpate? Is it standing in front or standing by the side or standing behind?
So standing in front of patient, sir.
What is Krill's method?
Sorry, sir.
Krill's method, C-R-I-L-E.
Krill's method, that is for the palpation of the nodule, sir. Examiner is standing in front of the patient. Then, with the help of the tongue, the one side of the lobe of sorry, sir, with the help of thumb, sir. With the help of the thumb, one side of the lobe is pushed, and the other side of the thumb of the other hand, it is used to palpate.
Krill's method, madam, that is not Krill's. You're getting confused with some other thing.
Krill's method is for the palpation of the nodule.
Lahey's method.
Lahey's method is for the palpation of the lateral lobes, sir. Lobes of the thyroid, sir.
Push the gland. Why are you telling it in the Krill method?
Yes.
Don't get confused. Lahey's method only, you will push the gland to the other side.
Yes, sir.
To feel for the nodules on the lateral border, which is covered by the sternocleidomastoid muscle normally. Okay, here also you have to mention this position of you. You standing in front or standing behind. Can you palpate from behind?
Yes, sir. We can.
How will you palpate?
Sir, examiner standing behind the patient with the neck in a slightly flexed position, sir. Then with the the ipsilateral side of the thyroid lobe is palpable from the same side of the hand, sir. With all the 4 fingers, it is palpable, sir.
Okay.
You mentioned no any other swelling. It looks like double negative. No other swelling is okay.
Yes, sir. I meant about the lymph nodes, sir.
Don't come lymph node. The previous case itself, they told you that it should be mentioned separately.
Yes, sir.
Proceed.
Go ahead. Go to the next slide.
Percussion, sir. There's a resonant note heard over the manubrium sterni.
Is there any meaning over percussion of the manubrium sterni when the lower body is visible on inspection itself? Is it required?
No, sir. No, sir. Not required, sir.
Similarly, in Berry sign, when there is a absent, will you auscultate or bruit? Nothing will be added. That is blocked, no?
Yes, sir. Yes, sir.
Only if there is thrill felt, you can auscultate for a bruit. You always correlate with your previous finding.
Yes, sir.
Okay.
Then the systemic examination, sir. Cardiovascular system, S1 and S2 are heard. Respiratory system.
The heart rate or pulse rate you mentioned?
Yes, sir. General physical examination I mentioned, sir.
What is the pulse rate?
104 beats per minute, sir. Tachycardic, sir.
Okay.
Then blood pressure was 140/90, sir. Millimeters of mercury.
So what was the rhythm of the pulse?
Sir, it was normal, sir.
Don't say you heard normal. A normal thing for you may be different for sir. Huh? You have to mention what are the things you see on palpation of a pulse.
Yes, sir.
But tell him.
Rate, rhythm, character, volume, we see, sir.
Similarly,
which
artery you have to mention?
Yes, sir. Break it. Radial artery.
Why I am asking the question, rhythm of the pulse. What way it is related to this patient or this case?
There will
What
be
type of arrhythmias you expect? That's the question, doctor.
Atrial fibrillation.
Atrial fibrillation. How will you find out atrial fibrillation? By palpation, palpating the pulse.
There will be irregular pulse will be there, sir.
Irregular pulse.
Double irregular.
Yes. Irregular pulse is present. How will you confirm the patient is having an atrial fibrillation? By examining an ECG.
Sorry, sir.
Can you find out atrial fibrillation in ECG?
Yes, sir. Yes, sir.
How?
So there will be absence of the P wave will be there, sir.
Yes. Why the P wave is absent in atrial fibrillation?
Because the contraction of this atria will be increased, sir. So it does not allow the relaxation of the.
Mind your words. See, there is absence of contraction, effective contraction of the effective contraction of the atrium. Hence, the P wave is absent. So, with the help of an ECG, we can confirm, even without seeing a patient, with the help of an ECG, we can say this patient is having atrial fibrillation. Yes, it is one among the important cause of atrial fibrillation. You know what are the other causes for atrial fibrillation? Though it is not surgical, so you can remind by writing the letter atrial, A-T-R-I-A-L, vertically, A for atherosclerosis, T for thyrotoxicosis, R for rheumatic heart disease, I for ischemic heart disease, and A for atrial myxoma, and L for lone fibrillation, where the etiology could not be ascertained.
Yes, sir.
Yes. Among this systemic examination, CVS, RS, abdomen, CNS, which one is important in this patient?
CNS, sir. And the CVS also.
Pardon? CVS is much
Yes.
more important. So in case of secondary thyrotoxicosis, we have got all this what we have discussed. Yes.
Yes, sir. Yes, sir.
In primary thyrotoxicosis, CNS, as I said. Okay. Next.
Summary of the case, sir. 38-year-old male patient with complaint of swelling in front of neck since 1 year, associated with increase of size and pain since 15 days, with symptoms of hyperthyroidism with no compressive features. On examination, being a multinodular goiter of size 12 cross 9 centimeter with well-defined borders, which moves with deglutition, firm in consistency, with no other palpable swellings in the neck.
See, I want to ask 1 or 2 questions in this. See, whenever you say moves with deglutition, you have to say moves upwards with deglutition. Okay. Moves upwards with deglutition. And does this patient have any eye signs?
No, sir. He had just the conjunctival congestion, sir. That's all, sir. Other than that, there were no eye signs, sir.
You have to mention about that. There is no eye signs. What are all the eye signs you are supposed to examine in a case of thyrotoxicosis?
Yes, sir. Von Graffi sign, sir. Then Dalrymple sign, sir. Then Mobius sign. Then Joffre sign, sir. Then lid retraction, sir.
All signs you must say. What will you expect in that case?
Should I elaborate, sir? Explain, sir.
Yeah, what graph is sign? What do you expect? What will be there? That you tell. You have to tell.
Yes, sir. Von Graffi sign, sir. There will be lid lagging will be there, sir.
Lid lag in this case, that is what we expect.
Yes, sir. Then Dalrymple sign, sir. That is lid retraction, sir. Then Mobius sign, sir. Inability for convergence, sir. Then Joffre sign, sir. There will be absence of the wrinkling when the patient is asked to look above, sir, with the chin being depressed. Then Stellwag sign, sir. There is a staring look with the increase of the palpebral fissures.
Annually called exophthalmos is there.
Yes, sir. When there is an increase in the palpebral fissure, sir, where the both upper eyelid and lower eyelid they are retracted, sir. That means whole of the cornea is visible, sir.
Visible. What is the cause for exophthalmos?
Exophthalmos, there will be retrobulbar cellular infiltration will be there, sir, with the edema and deposition of the fat, sir.
What will it produce?
So because of that, there will be protrusion of the eyeball, sir. There will be the deposition of this autoimmune complexes, sir.
Okay. Here you mentioned it as compressive feature, no compressive feature. Pressure symptom. It is called pressure symptom.
Yes, sir.
Okay. You don't see the dysphagia by yourself. It is a symptom told by the patient. Okay, use compressor symptom.
Yes, sir.
Then you have to mention it is non-toxic. What is the diagnosis? You have given summary. What is the probable diagnosis?
Multinodular goiter with secondary thyrotoxicosis. Sir.
So
Any-
already I think you have confused in the beginning. You said it was a primary thyrotoxicosis.
Secondary. Sir. Because
Are you clear now?
Yes, sir. Yes, sir.
Yes. You are saying it is multinodular goiter with secondary thyrotoxicosis.
Yes, sir.
Okay.
Yes, sir.
Yes, how will you proceed?
So specific investigations, then radiological investigations, sir. So in the specific, we would like to get the thyroid function test, sir. That is free T3, free T4, and thyroid stimulating hormone level, sir. Then antibody, sir. Anti-TSH antibody titer, sir. Then ultrasound of the neck. Then indirect laryngoscopy you would like to get, sir.
So you are allowed to do only 3 investigations. Which investigation you will do?
Thyroid profile, sir. Thyroid function test, sir.
At the outset, you will do thyroid profile, or you will find out whether it is thyroid gland, something else. First is anatomical diagnosis important.
Yes, sir.
It's only physiological. Third one only pathological.
Yes, sir. Ultrasound of the neck, I would like to get, sir.
What can you see in the ultrasonogram?
Yes, sir. Ultrasonography, it tells about the it diagnose anatomical diagnosis, sir, whether it's a thyroid, sir. Then it tells about the vascularity, sir. Then tells about the other findings such as cervical lymphadenopathy, sir.
No, in the thyroid, what else?
In the thyroid,
Vascularity?
Vascularity, then echo texture.
Can you see calcifications in the thyroid?
Yes, sir. Yes, sir. We can.
All those things you have to mention.
We can find out whether it is solid or cystic, or there are any cystic components within the solid. Okay.
Yes, sir. Yes, sir.
And what is halo sign?
Don't.
See, presence of halo sign is indicative of benign or malignant.
Benign, sir.
Yes. When halo sign is present, it says that tumor, the swelling is more in favor of benign. When it is absent, there is a possibility it may be malignant. Okay.
Yes, sir.
Apart from, as you said, sir said, microcalcification and all we can find out, and taller than wider, etc., etc.
Yes,
Then, see, anatomically you have done ultrasound, and you may also find out subclinical nodules, which you are not able to palpate clinically. We can find out the subclinical nodules as well as the lymph nodes. Okay.
yes,
Then, is there any role for CT scan in thyroid? Not
Yes.
pertaining to this case. What is the role of CT scan in a thyroid cell?
If we are suspecting retrosternal goiter, sir, then we would like to get CT scan done, sir, to roll out
Good.
pressure symptom, pressure features. Sir.
Then any other indication for CT scan?
Then to rule out cervical lymphadenopathy, sir.
See, the absolute indication for CT scan in a case of thyroid swelling is if you suspect extracapsular spread of the disease. If there is an extracapsular spread of the disease, CT scan is mandatory. That is the absolute indication. All other things are related indications. Okay. So you have done an ultrasound and you have evaluated the anatomy of the gland. Now, to assess the physiology of the gland, what are the tests?
Thyroid function test, sir. That is the free T3, then free T4, then TSH levels, sir.
Among the three, tell one test.
TSH, sir.
Which is, yes.
What do you
TSH
expect
is
in
the
this case?
most easiest and significant. Yes. Next.
What do you expect in this case in TSH level?
There will be fall in the TSH level, sir.
Okay. But you have to tell what finding you expect in a case, in any investigation.
Yes, sir.
See, this patient is on thyroxine. This patient is on beta blocker and anti-thyroid drugs.
Yes, sir. Yes, sir.
Do you expect a fall in TSH? See, if it's a de novo case without any treatment, as what you said is correct. There may be increased T3, T4, and TSH is suppressed. Whereas this patient is on treatment on beta blocker as well as anti-thyroid drugs. Do you know what anti-thyroid drug this patient is taking?
Yes, sir. Carbimazole 40 mg TID he is taking, sir.
What is the maximum dose we can give?
40 mg or the give?
Carbimazole.
Maximum 150 mg we can give, sir.
Sorry, doctor.
Your
we can give only
wrong.
60 milligrams per day. The dosage must be a total dose of 60 milligrams per day. Maybe 20 milligrams TDS. Otherwise, it may lead to adverse effects. What is the most significant side effect of this carbimazole?
Agranulocytosis, sir.
Agranulocytosis. What is agranulocytosis? What are granulocytes?
Yes, sir. There will be a decrease in the lymphocytes and WBC levels will be less.
See, the WBC is divided into granulocytes and what are the 5 types of WBCs?
Yes, sir. Neutrophils, lymphocytes, then monocytes, eosinophils, then basophils, sir.
What are the things which are not present?
Sir, what are the?
See, what do you mean by agranulocytosis?
The cells you take granules. That's what Sir is asking.
Yes, sir. Basophils, sir. Then eosinophils, sir. Then monocytes, sir.
Neutrophils.
Important.
So these cells may not be present. So it is a very important adverse effect of carbimazole. So you cannot exceed the dose of 60 milligrams. Even if you give 60 milligrams for a longer period, you have to check very frequently whether the patient is going towards agranulocytosis or not. Yes?
Yes, sir.
Okay, next slide.
What will you advise to the patient when she is on carbimazole to report to you?
Yes, sir.
When should she?
He's having sore throat, sir.
That is due to agranulocytosis. No.
Yes, sir.
It is given normally 20 milligram TDS, the maximum dose. As Star said,
yes,
it is not 40 milligram. You are not elicited correctly. When you elicit thyroid case, you must find differentiate between carbimazole or thyroxine. How to check on history? Whether patient is on thyroxine, this patient would have been on a long duration of thyroxine, developed a hyperthyroidism.
Yes, sir.
How to check whether she is on thyroxine or carbimazole?
Patient will take thyroxine empty stomach, sir, every morning. OD, sir. Then anti-thyroid drugs, the patient will take TID, sir.
Twice or thrice?
Thrice.
40 milligram, you cannot give 3 times. Understand? Okay. What else you want to do? Next it is pathological. What pathological test you want to do?
FNSC, sir.
What will you find here?
Sir, since this is a thyrotoxic case, sir, I would not like to do the FNAC, sir. Because of the hypervascularity, there will be chance of bleeding inside the thyroid tissue, sir. So when the patient euthyroid status is achieved, sir, then I would like to proceed with the pathological test, sir.
What will you be finding if it is going to be a case of papillary carcinoma?
There will be samoma bodies will be there.
Only one? Any other finding?
Orphan Annie appearance, sir. Those.
What else? The papillary, what do you expect?
Finger-like projections.
Papillary projection. It is called papillary projection. Can you diagnose follicular carcinoma in FNAC?
No, sir.
Why?
Sir, because follicular carcinoma, it requires a histological diagnosis, sir, whereas FNAC, it gives the cytological picture, sir.
Why can't you diagnose in FNAC? What are the disadvantage?
Because in FNAC, we cannot see the capsule breach, sir.
That is what you have to tell. Then you cannot see the vascularity.
Yes, sir.
Any other thing, sir?
Kanna, sir.
Arshia, you have made a diagnosis of multinodular goiter with secondary thyrotoxicosis. Okay.
Yes,
so why does the secondary thyrotoxicosis develops in a multinodular goiter? What is the reason for that? What is the most important symptom which is there of the secondary thyrotoxicosis developing over a multinodular goiter?
Patient is having palpitation, sir, involving the cardiovascular system, sir.
And what about the neurological system here?
Patient is agitated, sir. Irritation is there, sir. The nervousness is there, sir.
So have you done the neurological examination in this patient? I was not here for some time, so I did not hear about that. But can you tell what are the various neurological examination which is done in a thyroid patient?
Reflexes we do, sir.
Right, reflexes.
Yes, sir. Then tremors we see, sir.
Good. Yes.
Then muscular tone, sir.
Right. So what type of the myopathy is there in the patient with thyrotoxicosis?
Proximal myopathy, sir.
Okay, how do you test that?
Ask the patient to sit in a squatting position, sir, and ask the patient to stand, which he will stand with the help of the hand, sir. So there will be weakness of the proximal muscle.
Okay. So have you done the thyroid function test in this patient?
Yes, sir. Yes, sir.
Yeah. What was the report? Tell about that.
Sir, in the thyroid function test, we can see the increased level of the T3 hormone and the T4 hormone with fall in the thyroid stimulating hormone levels, sir.
Okay. Now, if you are having a doubt in a patient of a thyroid swelling, that whether the patient is having a hypo or hyper, then what test you will do first? You are given a choice of only one test. Yes, not sir. A group of the test, but just one test. Which test you will do?
TSH levels, I would like to see.
Right, you will do a TSH level. Okay. And then once you have found in the TSH level that it is abnormal, and then you want to know whether the patient is having the hypo or hyper, then which test you will do? You are given a choice only again one test only.
Then a T4, sir.
Okay, which T4?
Free T3-4, sir.
Free T4, right? Okay, so if you have to choose between free total, free T4 is the one test which you will carry out to make a diagnosis of that. Right. So what is it suggests here in this report? Yeah, the patient is having
hyperthyroidism, sir.
Hyperthyroidism is there, because the TSH is very low here, isn't it?
Yes, sir.
All right. Okay. Then what next test you have done? Any other test you have done?
Then ultrasound neck was done, sir.
Okay. What was in your mind to do the ultrasound of the neck here?
Sir, first for the anatomical diagnosis, sir. Then to rule out any nodularity, then if it is cystic or odd, sir, then for calcifications, and then for cervical lymphadenopathy, sir, and then vascularity.
Okay. And if there is any doubt about the malignancy is there, then what is the role of ultrasound?
Then ultrasound, it gives us the score, sir. Thyroid score. So based on that, the cytological test can be done, sir, in the form of FNAC.
What is that score called as?
Thyroid, sir.
Thyroids, no? Thyroid score is there.
Okay.
Okay. So you've done the thyroid score and you find that there is one suspicious nodule is there. Okay, in a multinodular goiter, there is suspicion. You cannot take a blind biopsy. You have to take always the guided one. So you will do ultrasound guided FNAC from that.
Yes,
okay.
Sir.
Now you have done the guided FNAC and it comes out to be there's a follicular neoplasm is there. Okay, how will you proceed now?
First, after the preoperative preparation, sir, surgery I would like to do, sir, total thyroidectomy. Sir.
You do not want to do any other test? You have only done the thyroid function test and you have done the ultrasound.
Yes, sir.
So you do not want to carry out any, and FNAC has been done, and yes, it has come out to be follicular neoplasm. Right.
Yes. Indirect laryngoscopy I would like to do, sir.
Why it is called as indirect laryngoscopy?
Because the mirror we use, sir, we see the indirect image, sir. Okay. Directly it is not seen.
And who does the direct laryngoscopy?
ENT specialist.
ENT specialist, they usually do the indirect one, or if they are having the fiber optic with them, then it is okay. Yeah.
Anesthetist will do.
Anesthetist will do the direct laryngoscopy. Yeah, no?
Yes, sir.
Right. So in this patient, the patient is toxic. So you want to go directly for the thyroidectomy in this patient?
No, sir. First, I would like to optimize the patient, sir, to euthyroid state, sir.
Yes. How will you optimize that?
Start the patient on an anti-thyroid drug, sir.
Which one you are going to use?
We use carbimazole or propyl thiouracil we can use, sir.
So which one you will prefer if you have a choice for that?
Carbimazole I would like to use.
Okay. How much dose you are going to give?
Sir, 20 milligram it is given, sir. Thrice a day it is given, sir.
5 to 20 milligram. Okay. Right. And how long you are going to give it?
8 to 12 weeks, sir.
Okay. So in 8 to 12 weeks, probably this may come under control now. Okay. Yes, now this is under control now. Now you are preparing for this. You are preparing for the total thyroidectomy here?
Yes, sir. Yes, sir.
Okay. So before you go for the total thyroidectomy, what are the investigations you are going to carry out?
Sir, all other routine hematological investigations will do, sir, with the ECG. Then, as I said, ideal will be done, sir. Will
you do a serum calcium or not?
Yes, sir. Preoperatively, serum calcium is done, sir, to keep as a reference. Sir.
Okay. Right. And then you will do X-ray of the neck?
The neck for X-ray neck.
Yes, sir.
Lateral view.
Yes, sir. X-ray of the neck is done, sir. PM the lateral view it is done, sir.
For what?
To look for the soft tissue involvement, sir. Then that position of the trachea, sir, which will be helpful for anesthetist.
So suppose the patient has got cervical spondylosis, will you not inform it to the anesthetist?
Yes, sir. We should inform, sir.
All those things you must tell.
So why you do the AP and why you do the lateral? What is the purpose of doing the AP X-ray?
Yes, sir.
And the lateral X-ray?
AP view, we can see the position of the trachea, sir.
So and deviation of the trachea, no? You want to see the deviation of the trachea.
Yes, sir.
Okay. And its importance will be for the surgeon or for the anesthetist?
For anesthetist, sir.
For the surgeon also. Okay. Normally you want to see that trachea in the central part. but it is shifted to some other place. So if it is not careful, you can damage the recurrent laryngeal nerve. Okay, so you have to be, so it is both for both surgeon as well as anesthetist.
Yes.
And why the lateral view?
To look for the vertebrae, sir, or any spondylosis changes, sir.
No, from the thyroid point of view. Why you want to do the lateral? And its importance for the surgeon as well as for the anesthetist. In the lateral view, you will see the compression of the trachea. Okay, in anterior view, you are looking for the deviation of the trachea. While here you are looking for the compression of the trachea. And if the trachea is compressed, then what kind of the problem?
There will be difficulty in intubation, sir.
Intubation may be there, yes. So anesthetist has to use the smaller size tube.
Yes, sir.
Yes. And surgeon's point of view?
Post-operatively.
Yes. Like you do a total thyroidectomy in a compressed trachea. Okay, trachea is compressed and you are doing a total thyroidectomy. So what can happen after that?
Post-operatively, stridor can occur.
Trachea can collapse.
Yes,
No? What is that called as? What is that trachea called as?
Tracheomalacia.
Tracheomalacia, or any other name for that?
Scabbard trachea.
Scabbard trachea, yes. So if there's a scabbard trachea is there, tracheomalacia is there. So once you remove the support from the trachea by doing a total thyroidectomy, this may collapse. So this patient may require the prolonged intubation, or even the tracheostomy may have to be done.
Yes, sir.
So the X-ray of the neck is very important, both for the surgeons and the anesthetist point of view. Okay, so you have done all those things. Now you are taking the patient for
Total thyroidectomy.
And you have prepared this patient with the carbimazole. So do you want to add any other drugs before you go for the surgery?
Yes, sir. A beta blocker, I would like to add, sir, particularly a propranolol, sir.
Yes, so you like to use the beta blockers. Any other drug which has to be in a patient who is thyrotoxicosis, any other drugs which has to be given?
Yes, sir. Potassium iodide, sir. Lugol's iodine.
So Lugol's iodine is one drug, but usually nowadays it is not given. Any other drug? Any other drug which is used? Because these patients are very apprehensive. So you have to give like the patient the alprazolam or something like that. You know? Anxiolytic drugs has to be given to these patients.
Yes, sir.
And when you are preparing, you are the resident and you are preparing the OT list. And there are 6 cases are there. Where you will keep this case?
First case, sir.
It has to be always the first case. Okay. And reason for the first case is?
Because when we operate the post-operative complication, we can look, sir.
Yes, the post-operative you can look for a long time. But more important, these patients are very anxiety. So if they stay in the operation theater for a long time, even in the pre-operative area, they can get the attack of the anxiety. So you have to, that is why you want to keep these patients in the pre-operative area for a very short time. And that is why these patients should be taken as the first case in the operating list. Okay. So patient is prepared. You are taking this patient on the operation table. What will be the position of the patient?
Rose position, sir.
What is that?
Neck will be extended, sir. By placing a sandbag in the scapular region, sir, and the head resting over a gel head rest, sir.
Okay. Then anything else?
With the hands tucked, sir.
Hands stuck on the side, yes. Anything else? Which you discussed in the parotid also.
With the head end up, sir.
So 15-degree head up.
Yes,
so that was the position. Okay. How will you make incision?
Sir, 2 centimeter above the sternal notch, sir. Coacher's incision. It is given, sir, around 5 to 7.
It is always fixed 2 centimeters.
a 2-finger breadth above the suprasternal node, sir.
Does the size of the thyroid makes a difference in the level of the incision?
Yes, sir. Yes, sir. It does make sense.
Yes. So depending upon the size of the thyroid which is there, your incision may be 2 centimeter or even 3 centimeter, or even just may 1 centimeter, depending upon what is the location and the size of the thyroid which is there.
Yes, sir.
How will you identify the recurrent laryngeal nerve?
Sir, it usually crosses perpendicular to the inferior thyroid artery, sir.
Where you will look for?
Near the tubercle of Zucker-Candle, sir.
Is the tubercular Zucker-Candle present in all the thyroid cases?
No, sir.
It's only about 30 to 40% you will get the Zucker-Candle.
Yes, sir.
But where you have to look for that? What will the place?
At the Berry's ligament, there also we can see, sir, attachment of the Berry's ligament. And then for the inferior pole of the thyroid lobe, sir, there where the inferior thyroid artery it crosses, sir, there's a recurrent injury, it enters the cricothyroid membrane at 90 degrees, sir.
Okay, so you have to, for if it is asked, you have to use the word that you are going to look into the tracheoesophageal groove. Okay, that is the place where most of the recurrent laryngeal, it may not be there, but that is the commonest place where the recurrent laryngeal node is there. Okay, right.
Yes.
What structure is there on the superior thyroid pole of the thyroid? What are the various structures which are there on the superior pole of the thyroid?
External branch of superior laryngeal nerve.
Yes. Anything else? On the superior pole of the thyroid.
Superior thyroid artery, sir.
And vein also.
Yes,
All
sir.
the three things which are there. Okay. And on the inferior pole, what are the structures? Inferior pole?
Parathyroid, sir. Superior and inferior parathyroid, sir.
Not on the inferior pole. On the inferior pole, what are the structures there?
Inferior thyroid artery, sir. Then recurrent.
Thyroid artery is not there. It is not there. Inferior thyroid artery is not on the inferior pole.
Recurrent laryngeal nerve, sir.
No, that will be not there. It is only inferior thyroid vein which is there. Okay, which may be one or more on the inferior pole. And that is why, all the three vessels which are there in the thyroid, they have got their partners in the different manner. At the superior thyroid, artery and vein are there. On the inferior pole is the inferior thyroid vein only. Artery is separate. And then there's a middle thyroid vein which is alone. There is no artery or the middle thyroid artery. Okay, so all the three structures which are there, they have got the different partners. Right. How do you identify the parathyroids?
Sir, they will be present in the inferior part of the thyroid, sir. There will be brownish color, sir, which are embedded by the in the adipose tissue, sir. It is surrounded by the adipose tissue.
How many parathyroids are there?
4, sir.
And what is their blood supply?
Inferior thyroid artery, sir.
It supplies all the 4 parathyroids. Inferior thyroid artery supplies all the 4 parathyroids. Okay. So if you are not sure that is it a fat tissue or it is a parathyroid is there, can you give some dye to find that?
Yes, sir. Indocyanine green.
ICG can be used or the methylene blue can be used for that. These are the 2 things which can be used. Okay, and if in case if you have removed the specimen and you want to make sure that is it a parathyroid or it is a fat lobule, what you will do?
Frozen section, sir.
If you do not have a specific frozen section, anything easier than that which can be done.
Aspirate for the PTH hormone. Sir.
But PTH hormone to calculate is very expensive. Any simpler thing which can be done? You do a water dip test. Okay, so you take a glass of water and put that tissue in the water, what will happen if it is fat and if it is parathyroid?
If it is parathyroid, it will float, sir. The adipose tissue will float, sir. If the parathyroid, then it will sink.
No, it usually doesn't sink down, Jana. And that is the way you can differentiate whether you are dealing with a case of a parathyroid adenoma or it's a normal parathyroid. So fat will float, parathyroid normal, which will be there, it will be in between. And if the parathyroid adenoma is there, it will sink down. Jana.
Yes,
So
sir.
it's a simple test by which you can find out whether it is a parathyroid or not. Okay, you have done the total thyroidectomy in this patient. What are the immediate complications and in-hospital complications?
Yes, sir. Immediate complication, there will be a primary hemorrhage, sir, leading to the difficulty in the breathing, sir.
You know what is primary hemorrhage? What does that mean?
Occurring hemorrhage occurring on the table, sir, on the within few hours.
Yes. So what will happen once you operated this patient? What type of the hemorrhage will be there?
Primary hemorrhage will be there, sir.
That is on table. You know, when you are operating, that is the primary hemorrhage.
Yes, sir.
The patient has been operated and the patient develops with the hemorrhage.
Yes, sir.
How he will present and what is this type of the hemorrhage?
Reactionary hemorrhage, sir.
The reactionary hemorrhage. And how the patient will present? This
Patient,
hemorrhage?
yes, sir. Patient will have the difficulty in breathing, sir.
So the patient may not have the hypotension as in other hemorrhage which is there, but here the patient will present with the breathing problem.
Yes, sir.
So what are you going to do if you are finding in a patient who is having the breathing problem? What are the various causes of breathing problem after the thyroid surgery, apart from the hemorrhage?
Yes, sir. Due to the repeated intubation or difficult extubation, sir, from an aesthetic point of view. Then for the injury to the recurrent laryngeal nerve, sir, intra-op finding. Then the post-operative because of the hematoma which compresses over the trachea, sir. Then
now you are suspecting in this patient there is a hematoma which is compressing that. As a resident, what is your action to do?
yes, sir. First, I would like to check the pulse and BP, sir. Then call for the help, sir. Then maintain the IV fluids. Then I would like to examine the surgical site, sir. If there is any active wounds or a brawny induration surrounding the incision size or any ecchymosis, sir. And I would like to also look for the drain, sir. If there is any increased collection in the drain.
So what will be your action? What you are going to do?
Sir?
What you are going to do for this patient so that the patient can be eased because of the hemorrhage which is there?
Yes, sir. I would like to open the suture, sir.
Which sutures you are going to remove in the ward? The patient is with you in the ward. Okay. So what sutures you are going to remove in the ward?
So the skin sutures I will remove, sir.
And the platysma sutures.
Sir.
So you can remove the skin and the platysma sutures in the ward and immediately shift the patient to the operating room. And there what you will do?
Strap muscles suture I would like to open, sir. And then I would like to see for active bleeding site, sir. Then control it.
So which is the commonest site of bleeding in a case of a thyroid surgery? What is the commonest site?
So which pole is more prone for bleeding?
Middle thyroid vein, sir.
Middle thyroid vein usually, when you are operating that, you will find immediately there.
Yes, sir. From the
But
middle.
which is the culprit one which causes the reactionary hemorrhage?
Anterior jugular vein, sir.
No, it is some artery which is there.
Superior thyroid artery, sir.
One is the superior thyroid artery and Okay, it is usually from the branches which are there of the inferior thyroid artery. Okay, because those branches in between is running the recurrent laryngeal nerve. And that is why, you are very careful at that point that if you take a bite in that area, you will catch hold of the recurrent laryngeal nerve. So the superior thyroid and this area is the main area for the bleeding there.
Yes, sir.
When does the hypothyroidism, this parathyroidism develops? When it will occur?
When there is a injury or a infarction of the parathyroid gland, sir.
When it will occur? After you have done the surgery today? After how many days the patient will present with the feature of the hypocalcemia?
Post up day 1 we can see, sir. Immediately there will be.
Not immediately. It never occurs immediately.
24 hours it will take, sir.
24 to 48 hours after that. And what is the first sign of having the hypocalcemia which the patient may complain?
Perioral tingling sensation, paresthesia.
So what are you going to do for that patient if the patient is having this problem?
I would like to send for the serum calcium level, sir. Then
what precaution you take when you are sending the blood for the serum calcium level? When you are sending as a resident the blood sample for the serum calcium, what precaution you have to take?
The tourniquet is not tied for too long.
Tourniquet is not applied,
Yes, sir.
You should not compress. If you compress with the tourniquet, there will be results will not be normal. Okay.
Yes.
Okay. Doctor,
I'll ask one or.
Yeah, please.
I'll ask one or two questions.
Yeah, please ask. Yeah.
See, when will you call the recurrent laryngeal nerve injury as permanent?
For a period of 6 months, sir.
Yes, if it is more than 6 months, then we call it as permanent recurrent laryngeal nerve injury. The same applies to parathyroid also. If it is present, if the hypoparathyroidism is present for more than 6 months, then it is called as permanent hypoparathyroidism. Okay.
Yes, sir.
Sir, Jawahar, sir.
See, the specimen sent for HP comes as malignancy. How will you proceed?
Then we would like to do the resurgery, sir. With
Resurgery. Before that is something has to, something you have to do.
Thyroid replacement we have to give, sir.
No. The biopsy report is coming as malignancy. How will you proceed? What test you will do? I'll give you a clue. How will you find out the residual thyroid?
Radioactive nuclide scan, sir.
Which one?
Iodine 131, sir.
Okay. You have established. Then what will you do? There are some tissues are left. What will you do?
Then central neck dissection. We have to.
They're doing a central dissection or give some ablation.
Yes, sir.
Is it easy to do a second surgery in neck?
No, sir.
Which iodine they give for ablation?
Iodine 123, sir.
Are there any precautions before the treatment and after the treatment?
We have to look if the patient is breastfeeding or lactating, sir. Then we have to keep the patient in a quarantine, sir.
Patient to be separated. She should be kept alone.
Yes, sir.
Long after ablation, you will release the patient from that cubicle.
6 weeks, sir.
You have to advise the patient to use a separate toilet. Understand? Should not use the common toilet.
Yes, sir.
sir.
So what is the half-life of iodine 131 and iodine 123?
Iodine 123, 24 hours, sir.
Iodine 123, ma, you gave it for ablation.
See, what is the half-life of iodine 131? 131 is 8.4 days. And iodine 123 is 13 hours. And we can use technetium also for thyroid scanning, the half-life of which is 5.5 to 6 hours. So if technetium is available, can you use technetium or iodine 123?
Technetium, sir.
Why?
Because lesser half-life, sir. So there will be a systemic toxicity will be lesser. And it will be easily metabolically excreted, sir.
You do a total thyroidectomy and you have left some tissues, thyroid tissues. How much percent is present, then we have to go for ablation, iodine ablation, radioiodine ablation. If the residual tissue is how much percent? If it is more than 8%, we are supposed to go for radioiodine ablation. If it is less than 8%, there is no need for iodine ablation. We can control with TSH suppression.
Yes, sir.
Iodine scanning will be done after 6 weeks. In that case, you cannot do resurgery. If you're doing resurgery, you can do it immediately, not after 6 weeks. Okay, you have to wait for 6 weeks to do uptake study.
And the TSH level has to reach at least 25 to 30 micro international units for radioiodine uptake studies or ablation, radioiodine ablation. Without this level, it may not, the radioiodine may not uptake well. Okay. So the TSH level must reach 25 to 30 micro international units. That's for which we need 6 weeks.
Yes, sir.
Dr. Kenel, can we stop now?
Yes, sir. It's 10:40 almost. I think this girl could cope up with all the questions and really, I think credits to the teachers and the hard work done by the student. In fact, she had very little time to prepare, sir. In fact, I could not connect to her early and she had to prepare the PPT only this evening. In spite of that, I think she has done well.
Extremely well, sir.
Yes, sir. Yes, sir.
Thank you.
Both the candidates done well. They had to slightly correct themselves. That's all.
Sir, this is a teaching forum only now, sir. This is not like an examination. So these people have an opportunity to learn from all the senior faculty.
Learn more. You are conducting every Friday general clinic. That is a very useful procedure.
You are welcome to join all Fridays, sir. I think Kanna sir is the senior most person.
From the day you started this program, I have made my PGs to join with you.
Thank you very much, sir. Thank you very much. Maybe you can also permit any abdomen case for the next week from your PG side, sir.
Okay, sir. I will give you the name tomorrow, and you can give the case.
Yes, sir. Dr. Arshia, do you have any doubts or clarifications from the senior faculty here, ma?
No,
Share you with us? Do you have any doubts to be clarified?
No, sir. No.
Okay. So with that, with the permission of the faculty, we call the session a close. I thank all the students who have joined in the YouTube and the Zoom for this evening class. On behalf of all the faculty, we wish all of you a very happy New Year, and we look forward for yet another interesting session coming Friday. Thank you.
Thank
Thanks
you.
are due to Dr.
Happy New
Omkar
Year.
and
Thank
Dr.
you, sir.
Arshia.
Happy New
Thank you
Year.
very much for contributing yourself for this teaching purpose. Thank you very much.
Thank you, sir.
Good night, sir.
Thank you. Happy New Year, sir. Happy New Year to all.
Happy New Year to everyone.
Thank you, sir. Thank you, sir. Ravindran, sir, thank you very much.
Thank you, sir.
Thank you, sir. Thank you. Good night, everyone.
Good night.
Good night.
Good night.
Good night. Good night. Kanna, sir, can we close?